So I'm going to start the presentation. Next slide. So I just wanted to start really by thinking about, the general public's awareness of psychosis. We only hear about psychosis when the media portrays it from a very negative view. So when something has happened, either there's been aggression or violence or someone's been killed, which happens very rarely in people that experience psychosis. So I'm hoping that if there's anything that people take away today is that people that experience psychosis are not violent, they're not, aggressive. They can be, but it is very rare. Most people have experienced psychosis as a medical dysfunction, and it is treatable. So what is psychosis? Psychosis is a mental illness that affects how a person thinks, how they feel, how they behave. So it has effects on those three areas of their life. And it makes it very difficult for them to be able to think clearly. As I've already mentioned, it can occur due to a dysfunction in the brain. And I'm sure a lot of people, the commonest symptoms that people are probably aware of is that they hear people have hallucinations or delusions. And that's why I've just touched on them very briefly there. I will expand later on some of the symptoms of psychosis. But just to say very quickly that hallucinations is experiencing something, a perception that is not real. But to the person who is experiencing it, it feels very real. And it can be in the form of hearing noises or voices, which we call auditory hallucinations. Sometimes people see things that are not there. That's visual hallucinations. Sometimes they feel things, or sometimes, they experience other various ways. It could be tactile, it could be somatic, and it's all related to what the person is experiencing, which feels very real to them. And delusions, just in brief, is when somebody has a belief that is not true, there's no evidence to it. On rare occasions, it might be true. So somebody might believe that their wife, is having an affair, or their husband is having an affair, and it might be true, but they have no evidence for it, and they take that to the extreme. But in most cases, it's not true. So very commonly, people will feel that they're being watched. They might think that cameras watching them through their phone, through their TV. If their camera is hanging above, they think that people are watching them. Sometimes they think there's a conspiracy by the government. Sometimes they think that their food is being poisoned. So these are all delusions. There's no evidence that this is true, but the person feels it like it's true. And it's very difficult to convince them that it's not true. And psychosis doesn't start in childhood. It usually starts in late adolescence. So you will commonly find somebody who is experiencing psychosis for the first time being somebody who's probably gone off to university. They might have experienced with cannabis or with drugs, and then they suddenly start to exhibit some symptoms. So usually it starts in late adolescent, for women, usually in their 20s. Next slide. So I wanted to use this to just say that, a lot of people experience symptoms that pertain to psychosis in the form of, they might hear things, they might believe conspiracies, for example, alien abduction. We've heard people who believe strange things are happening, ghosts, telepathy, and so on. Does that mean that they're psychotic? No. So there's a spectrum. People can have certain symptoms, but it doesn't mean that they fulfill the whole spectrum of psychosis. The people can experience these symptoms as well when they're distressed. So you might find that somebody is going through a very difficult time, stressful time. Maybe they've lost someone, maybe they've lost money, maybe they're doing exams, maybe they haven't slept in 5 days, they're grieving. They might start experiencing symptoms of psychosis. But for a lot of these people, this experience is usually resolved fairly quickly. Next slide. So what are the risk factors? It's not always as clear as when you talk about diabetes and hypertension, and you can say this is the definite cause. For psychosis, there are risk factors mixed with genetic factors that can predispose someone to experience psychosis. So, for example, early infection in the mother during pregnancy. Some people say winter births. Some people say low birth weight. If there's brain infection in infancy, if the person has experienced trauma in childhood, whatever form of childhood abuse, it can predispose them. Social adversity or poverty. So again, when we say that someone has experienced something that's been quite distressing, it can predispose them later in life. Cannabis, we're finding that quite a lot of people that come to early intervention services for first episode psychosis have used cannabis. Not saying that everyone who uses cannabis will have psychosis, but it does predispose to psychosis. A lot of people, who have emigrated from their own country. So you can imagine somebody who is in a different land, traveled a long way, has gone through ethnic segregation, can be predisposed to psychosis. And then the genetic risk factor. So there isn't a particular genetic risk for psychosis, but people whose parents have had psychosis have a much higher rate of having psychosis. It doesn't mean that they will have it, but they're more predisposed to getting it. Next slide. I've touched on some of the causes of psychosis. So this slide really, apologies if you can't read it, but I tried to talk about what is on the slide. So I've said substance use, and I've already touched on drugs like cannabis, cocaine, alcohol, all of these can cause psychotic symptoms, LSD, amphetamines, whatever drugs that you use can predispose you to psychosis. For some people, they might experience the symptoms very briefly, and within 1 week of stopping the drugs, they stop experiencing the psychosis, and they might not need treatment. But for some others, it can predispose them to a fuller acute syndrome, and then they need to be treated with antipsychotics. Difficult life events I've already touched on. So it can usually be a response to what is happening in our lives, trauma of any sort. And then, people start then hearing voices, which is the most common psychotic symptom. And people always think that it's voices. It can be music, it can be sounds, it can be, very commonly somebody, and it's usually in the evening. So you find that when people are not as distracted during the day, so at night when things are quiet, they tend to experience these symptoms more. So they focus on, they can hear their neighbor upstairs talking about them, or they can hear through the wall their neighbor is talking about them, or people are threatening to kill them, and this is it feels really real to them, and they live in fear. So people might not go out, they might draw their curtains, they might think that somebody's going to persecute them should they leave their house. So all this starts to affect the way they interact with life. And then the other thing is neurochemicals. So there's a neurotransmitter in the brain called dopamine, and usually this in normal levels helps us in how we experience things, pleasure, just general like day-to-day events. But when there's a problem with the transmitter, usually when it's quite high, it can then translate to people experiencing some of the symptoms that I have talked about. Next slide. So there's a prodromal period just means that before you get the full psychotic symptoms, there's usually a period ranging from a few days to over a year sometimes, where people just slowly start to change. So you might notice that, the person is not the way they used to be before. They become more withdrawn. They don't talk as much. Their memory or their concentration might be poor. They might be very fixated on what they're experiencing internally and not be as communicative as they used to be before. So you might start to see unusual behaviors and just a lack of interest in their usual activities. And that's called the prodromal period. Next slide. So this slide, really, I've tried to tailor this presentation to not be too caught up in, difficult words and trying to tell you about all the diagnoses that you can see on the slide. But I think it's worth knowing that there are different causes of psychosis. And I will start from stress and poor sleep. So when people are stressed, you've got to be careful. Anyone under extreme stress or has not slept can be predisposed to experience psychotic symptoms. So I always say that if people are experiencing really poor sleep, very stressed, do not hesitate to go to your GP, because just getting something to help you sleep can prevent you from, switching on to something more acute. But the ones people usually know about is schizophrenia. Schizophrenia is not it's just one of the disorders that causes psychosis. We've also got delusional disorder. So for schizophrenia, you have a range of psychotic symptoms. I've already touched on hallucinations, delusions, how, people have problems with their thinking, they have problems with their memory, they have problems with, how they perceive what people are doing. They can be fearful. They can feel that things are referring to them when it's not. Whereas with a delusional disorder, it's usually just that one delusion. So people might be going to work. They might be able to do everything without worry, apart from one particular thing that they're fixated on. That's the delusional disorder. You probably know about bipolar disorder, which is a mood disorder. And people can have periods of depression, or they can have periods where they have really high moods, which we call mania. But when they have the symptoms, they can also experience psychosis. When people are depressed, if you don't treat that depression on time and it becomes severe, you can experience psychotic symptoms. I wouldn't go too much into the disorder because it's quite complex, but we have different personality disorders, and for some people, especially who've had trauma in younger life, they can go through. They're more predisposed to psychosis, more predisposed to depression, anxiety, and all sorts of mental disorders. Also, we've got postpartum psychosis. So this is when people have just given birth. Usually within the first 3 months, people can be predisposed to experience psychosis, and it's usually quite treatable, but it can be quite serious. So if it's not treated, it can have really negative experiences. So it's usually good to get a psychiatrist to see the person and treat them quite quickly. You can have, I said, medical problems can trigger psychosis. So in terms of medical disorders, the list is very long. There are lots of medical disorders that can cause psychosis. It could be your kidneys, your thyroid, most organs. But the commonest ones we try to look for is to make sure there isn't a brain tumor. So you will see that some of the investigations that are done when people experience psychosis are things like CT of the brain or MRI scans of the brain, just to make sure there isn't a brain tumor. But also things like epilepsy, particularly temporal lobe epilepsy, can cause psychosis. Delirium there that you can see just means that usually is more on the elderly. So when people are predisposed to infections, anybody can have it. They can go through what we call delirium, and in this sort of stage, they might start to experience psychotic symptoms. It can also happen in dementia. And the last one I've got there is head injury, which is not a very common cause. Next slide. So I'm aware I'm talking to you now, but as Dr. Ajayi said, we will have a period of time to discuss this in more detail. But I've just touched briefly on schizophrenia here, and I've already said quite a few of the symptoms of schizophrenia, but we say first rank symptoms of schizophrenia, and they're listed there. I hope you can see them all, but when you've got the symptoms, they usually tell the psychiatrist that this is most likely schizophrenia. So there are lots of symptoms you can have in schizophrenia, but if you start having auditory hallucinations, when we say third person, that means that person is talking, to you and referring to you. Sometimes running commentary, which means that they're talking about, oh, there she is, she's going off again, she's doing this, she's doing that, that's running commentary. Usually it points to schizophrenia. Delusional perception, without making it too complex, is something that is very normal. So you might just have red roses in your window, and that will tell that person that you're trying to kill them. So they will see something that is a normal perception, and they will infer a belief system from that normal perception. People can sometimes feel as if their thoughts have been emptied. So thought withdrawal, that somebody is controlling their thoughts, has taken thoughts out of their head. They can sometimes feel as if thoughts are being inserted into their head. They can feel that people can hear their thoughts, which is thought broadcast. And they can feel like somebody is controlling their actions, which is the mate perception bit. So those are the symptoms of schizophrenia. Next slide. So I have already explained this. I won't go too much into it, but I've just put another slide in because these are the commonest symptoms that you will get in psychosis, as I said. So hallucinations, the person hears, sees, smells, tastes, or feel things are not there. And the most common, as I said, is the auditory hallucination. And then the delusions, as I've already said, the unusual beliefs, I'm being followed by the FBI. They can't explain why they're being followed by the FBI, but they believe it 100%. They see normal, people in the public. They believe they're following them, or they see cars. They believe they're being followed. These are all delusions. And then disorganized thought disorder. So that, as I said, when you've got psychosis, your thoughts can be affected. Your thoughts could be slowed down, or it could start racing. People might be talking and you find it difficult to understand what they're saying. Their thoughts can be muddled, and that's all effects from the psychosis. Next slide. So we don't just have positive symptoms, which are added symptoms. We also have negative symptoms, which are when things are taken away. And by that, I mean, you have somebody with reduced emotions. You start thinking, this person is not as sympathetic to me. You feel like they don't have as much empathy, but that can be a symptom of the illness. It's not that the person is being unkind. They just have reduced or flattened emotions as part of the disorder. You have reduced communication or interaction. So some people actually can stop talking. We say they're mute. They might just stop talking. They might become very slowed down, not just in their speech, but in their movement. Sometimes people become catatonic. They can't move. All parts of the symptoms. They have decreased levels of motivation and a lack of energy. So, some people might say, oh, he's being lazy. But no, he's not being lazy. It's really because he lacks motivation, he lacks energy, he's not able to study. And so they start to do badly in exams. But it's really because of the illness, what they're going through. They have a lack of enjoyment, and so they don't want to socialize with their friends anymore. And they're usually less able to concentrate or to attend to normal day tasks. And sometimes, people start thinking, is this dementia? What is this? But actually, it's negative symptoms. So things are taken away from the way the person behaves or interacts. Next slide. So when we have, I think it's probably important here to say that if you know someone who you think is experiencing psychosis or has any of the symptoms, the most important thing they can do is to get treatment as early as possible, because the earlier you treat this, the better the prognosis. We call something DUP, duration of untreated psychosis, which has a direct correlation with the prognosis of the illness. So the longer the duration of untreated psychosis, the poorer the prognosis for the person. So the person who goes to the GP within 6 months, gets referred to the psychiatrist, starts medication, will have a much better prognosis than somebody who has the symptoms for 3 years, and people are thinking, what is this? Is this spiritual? Is this, and not really getting help. That doesn't help the prognosis of the person. And those people are more difficult to treat in the long term as well. So what we would normally do, so you would refer to a GP. A GP is not able to start antipsychotic medication. They have to refer to a psychiatrist. So that we refer to mental health services, where a detailed history will be taken, and we do what we call a mental state examination. And that just means looking at the person's appearance and behavior, their speech, their mood, their thoughts, how their concentration, and so on. So there's a detailed history taking that happens. We do a physical examination because we have to rule out any medical problems. So we'll do a proper physical examination. We will take bloods, do bloods to make sure to rule out any physical causes. Sometimes you have to do an EEG just to rule out epilepsy, and the cognitive assessments for dementia. People who have dementia, we do cognitive assessments for that.
So you're not watching it, is it clean?
Yes.
Okay. Can you use another cotton on the back of it?
Can you mute somebody? Okay. And then, okay, so we'll move to the next slide. So, yes, I was just going to say imaging studies. So, CT scan, MRI scan of the brain, which was what I touched on before. Next slide. So, a lot of people wonder about treatment. I think some people get very worried. I know a lot of my patients get very worried about where they're going to be sectioned, and we'll probably discuss that in more detail later. So we have inpatient services and we have outpatient services. The inpatient is obvious. Somebody's admitted to hospital. I can assure you there are no straitjackets. People are not, strapped down and, all of these things that you see in the media. No, they're admitted for a period of treatment, which usually includes medication and psychological interventions. When you admit people, it can be voluntary. So you might find that the person is very unwell, and you might say to them, I think you need to come into hospital, and they agree, and that's voluntary. Or it might be involuntary. One of the things I should have mentioned as part of the presentation of people with psychosis, that a lot of them do not have insight. So a lot of people, as you can imagine, believe that their symptoms are real. So when you say you need treatment, they disagree with you because they're saying to you, no, the FBI is chasing me. This person is poisoning me. I am experiencing this. This is real. So why would I take medication? So sometimes you have to section people, and that's when you then have the formal admissions. In terms of medication, as the name suggests, antipsychotic medications treat psychosis, and they bind to dopamine receptors in the brain and normalize those receptors. So that's the main thing that they do. And we have different types of antipsychotic medication, which I wouldn't go into today. And then in addition to that, we also encourage psychological interventions. So there's cognitive behavioral therapy for psychosis. There are other supports that we have. We have different professionals within mental health. So it's not just the psychiatrist who is prescribing medication. You have the psychologist who delivers the psychological interventions. You have the social workers because there are issues with social support and housing and so on. You have employment workers who will help that person get back into work, voluntary vocation, or back to university. So there's a lot of support. It's not just about giving medication, but it's also about supporting them in other areas of their life. And of course, if there's substance abuse, alcohol or drug use, then we recommend treatment programs for that. Next slide. So just to say a little bit more about antipsychotic medication. Antipsychotic medication treat the acute stage, but also maintenance. So a lot of people within weeks of taking medication will feel much better. The symptoms will resolve, and then they stop the medication. And what happens when they stop the medication? They relapse. Which, you know, we try to always make sure that we educate people right at the beginning. If you take the medication, I work with people with first episode psychosis, and I usually recommend that if this is your first episode, you take medication for at least a year, which people find very difficult, especially when they feel much better after a few weeks. Why would I continue to take this medication? Some of them do have some side effects. But as I said before, the important thing is to get the first episode to resolve and not relapse, because the more relapses you have, the poorer the prognosis and the more difficult it is to treat. So I always say, you know, if you can focus on just getting the treatment for a year, it saves you from having to be within mental health services for, you know, 10 years, 20 years, and so on. You know, what we really want is to treat people, get them better, discharge them back to their GP, and hopefully not see them again. But this might be a good time to just say that for a lot of people, that might not be the case. So for people who have one episode, they usually do quite well. They're treated, they might not have another episode. But once you have had a psychotic experience, there is a possibility that you can have another one. So we always work very hard to make sure that people can see relapse symptoms. And what do I mean by that? You know, before it gets to the point of hearing voices, are you having problems with your sleep? Are you beginning to worry about things? Are you getting stressed? You know, so we show them what the triggers are to avoid them getting to the stage where they need, you know, treatment in hospital and so on. It's also important that we monitor for side effects from the medication. So we do that. The medication can be given either orally or by injections. For people with depression, or if they've got bipolar or other illnesses, they might need other medications alongside the antipsychotic medication. Next slide. So I wouldn't go too much into this, but you can see on the slide there, it just talks about the actions, how antipsychotics work, and they work on neurotransmitters, and dopamine is the main neurotransmitter that is affected by these medications. Next slide. And that's just a slide that I wouldn't go too much into because of time as well. We have psychological interventions, and you can see there that it's delivered by psychologists. We also work very closely with families and carers. So we offer family intervention. We will meet with the patient and their family because, as you can imagine, when people are experiencing psychosis, it's very distressing also for family members. So we try to make sure that we meet up with the family and also give them support when needed. Next slide. So in summary, psychosis is a medical condition that occurs due to dysfunction in the brain. Only a small percentage of people will experience psychosis, and very small numbers experience schizophrenia, 1% over the lifetime of most people. Onset is usually late in adolescence for males and later for females. The causes are related to the developing brain and interactions from the genes. As I already said, people can be genetically predisposed, or the environment. So if there's a stressful environment or drug use, etc., that can lead to psychosis. People who get treatment early do better. And for most people with first episode psychosis, symptoms would resolve within weeks of treatment. Next slide. And on that slide is just showing you how to get help. The first point of contact is the GP, who would refer you to a psychiatrist or to a mental health team. If you're concerned about your family, for a very small number of people, they can sometimes feel suicidal. There's some information there about how you can get help. The Samaritans, A&E, call 999. And sometimes, not often, we might need to do a mental health act assessment. And that just means that the person might be a risk to themselves or to others. And in that case, if they're found to be sectionable, they're admitted to hospital under section. And we also have MIND, which is a national mental health charity. Next slide. Thank you.
Wow. Thank you so much, Dr. Matiola, for that whistle-stop tour. And you very carefully touched on all the stops that we need to touch on. So thank you very much for that. And thank you for just going ahead into the presentation. For those who were with us at the beginning, when I got dropped out of the call, Dr. Matiola is a consultant psychiatrist from ex-Oxley's NHS Trust, but she's also a clinical director in that very leading mental health trust. And she's been a consultant psychiatrist since 2006. And she's worked in early intervention psychosis, post-episode psychosis team for the last 13 years or so. So you can see that she comes from a very vast place of experience. In addition to that, she's been involved in lots of research and also quality improvement projects to better the lot of the service that we deliver to people who have experience of psychosis. And recently, our team has just won an award by the National Clinical Audit on Psychosis for the team that delivers services. She's also a member of the fellow of the Royal College of Psychiatrists, not a member, but a fellow of the Royal College. That's very important. So I'm really delighted to have Dr. Matiola present to us today. Whilst we're having this conversation, as we move into the next phase of today's meeting, I'm going to encourage everyone to please start typing in your questions. If you've got questions, to please type them in. And Dr. Matiola, I was just going to ask you, one of the things you emphasized, which I couldn't agree more on, is about the essence, the importance of early intervention, how important that is. And I was just wondering about your thoughts, because very often I have families or call-ups or friends to say, how do you encourage somebody to engage with treatments when they are lacking in insight, and I was just wondering from your experience, how you deal with that.
Thank you. It's actually, this is not directly in answer to your question, but I just want to share how I got into early intervention psychosis. So early intervention in psychosis teams were set up. We didn't always have these teams. They were set up about, I think, maybe 15 to 20 years ago. And one of the people actually who was crucial in helping set that up was a GP who is a colleague and a friend. And his daughter had schizophrenia. And when his daughter had schizophrenia, this was about, we're going to maybe 25 years ago. It was those days where people were treated with the older type antipsychotic medication. She was on a locked ward. She put on a lot of weight. And, he wanted something better for his daughter, and realized that if we could have these services that was concentrated for people experiencing psychosis for the first time and put in extra resources right from the first episode to prevent further relapses, then the person's life and prognosis was much better. So previously, Dr. Ajayi knows this, that a lot of people who suffer from mental health disorders usually live less, 25 years less than the general population. due to a wide variety of things, and so there's been a lot of resources put into mental health, particularly for psychosis, first episode psychosis, to try to get in as early as possible. And not just to get in, but to also provide psychological interventions, psychoeducation, not just for the patient, but for the family too. So we have family intervention, all directed towards educating the patient and the family about the importance of treating the illness. And it's not easy, as we know that people don't have good insight. But if you intervene as early as possible and provide that psychoeducation with family support, people tend to do better. So it's just working out just with the patient, but making sure that we also involve families and those that care for that patient.
Yeah. Thank you very much for that answer. Because I mean, one of the other things I consider is the fact that for people who, as you say, the age of consent is late adolescence and very early in the 20s. This is a time when people, with their formative years in terms of their social life, their careers, and really a lot of things could go wrong or go right if intervention is early. That's when people are choosing their careers, they're getting established in their careers, forming intimate relationships, and all of those can really, if the family are able to support them to get help. And that brings me to my next thought, because as we begin now enter into the realm of mental health assessment and all that, that in terms of, if you could just say a bit about the fact that when family feel that it's at a point where this person is no longer able to help themselves, what can family do in terms of what's the formal structures that are in place? For instance, maybe family being able to refer for mental health assessment and that sort of thing. Please speak to us about that a bit.
Yeah, and it's a very important topic. Thank you for asking about that, because for families, it's so difficult for them to refer someone for a mental health act assessment or to participate in getting that person sectioned, because the patient feels that the family has betrayed them. But actually, if you think about it, and you reflect on the presentation I've given you today, the earlier the person gets treated, the better their prognosis. So I always have this dilemma with the families, and I always say to my, to the families that you can blame it on the psychiatrist, blame it on me, blame it on the service, blame it on the professionals, but we encourage them to participate with mental health act assessments, because it's very difficult for you to be admitted to a psychiatric bed. People who are probably would have seen in the news that the beds are very expensive, and we don't just admit people for no reason. So for you to actually be admitted to a psychiatric bed is not as easy as people might think. You have to have two professionals, so a psychiatrist and a doctor who knows the patient, can be the GP or another doctor. You need another mental health professional, usually a social worker. All three have to agree. So it can't just be one person says this person should be sectioned. All three have to agree before that person can be sectioned. So there's a lot of safeguards to make sure that people are not just, denied their liberty and sectioned for no reason.
Thank you for that. Could I just ask that everyone mute themselves, please, except our speakers? Thank you. Right, I can see quite a lot of questions coming in. Thank you, Dr. Mitchell, for that very eloquent answer to that question. And as you are talking about it, I think it's nice that emphasize that really there's that a psychiatrist, another doctor could be a psychiatrist or even a GP or somebody else who might not know the patient, after agree with the social worker or that this person needs hospital, and that we don't keep people in hospital longer than they need to be, because we do know that the best place where people are able to recover is really with their nearest and dearest, but there are times when they are unsafe to be in the community. That's if we feel that there is risk of harm to themselves, in terms of maybe they're going to harm themselves by suicide or by harming themselves, hurting themselves, or doing damage to their health, or also because they are at risk of harm to others. And also maybe because if they don't go into hospital, their health further deteriorate. So I really really appreciate the fact that you've given reassurance in terms of the fact that we don't just take people willy-nilly against their will and put them into hospital. Because in my work in the community, I find that that's one of the things that people are worried about. Oh, is my child or is my brother or my uncle going to just be taken against their will and forced into hospital when they don't need to be there? So thank you for really helping us to understand that. And that brings me also to the next point in terms of how long do people tend to stay in hospital for? How long do they tend to stay in hospital for when they've been admitted into hospital for a psychotic illness, for instance?
Yeah, thank you for touching on, the reasons why people are sectioned. You've touched on very, very eloquently there. So the risk to self, risk to others, or risk of deterioration of health. When you're in hospital, it's almost that, you can be there for weeks, some people for months, but usually now it's more weeks because there's a lot of pressure on those beds. So sometimes we in the community are actually arguing you're discharging too early. I can assure you that no one is keeping anyone for longer than they need to be. You always have to justify why that person is still in hospital. So it's more of us saying that person is not here well enough. And, when is the end date? So right from when you're admitted, there's a plan on what the treatment is going to be. There should be input from the community. If you have a mental health worker who works with you in the community, they can attend ward rounds. Families can join ward rounds. And usually the psychiatrist in the ward will explain to you what the treatment is, what the goal is, and how long that person should be in hospital. For my experience, it's usually weeks. For if it goes more than weeks, then that person is very acutely unwell and they need to be there. So I can assure you that no one is keeping anyone longer than they need to in hospital.
Thank you very much for that, Dr. Matiola, in terms of really helping us to understand that nobody gets kept in hospital more than they really need to be, and that it's usually people get moved on to the community team as quickly as can be. Because the reality is that even these days, we don't even have capacity to keep people in hospital longer than they need to be anyway. So that's reassuring to them, because these are some of the things that I think are deterrents for people getting help and asking for help. And whilst we're on that, I just also wanted to acknowledge a few colleagues who are in the house this evening, because I do know that some of those colleagues might have things that they wanted to contribute to this very interesting conversations going on. And for those who are also members of the audience, I think this is a very distinguished audience. This is a very distinguished lineup of professionals, to be honest. I can see that Dr. Abi Padikwa is here in the audience somewhere. Dr. Padikwa is the medical director of Oxley's NHS Trust. And I dare say without bias that Oxley's Mental Health NHS Trust is one of the leading mental trusts in this country. I think without bias, it's one of the leading ones. Yeah. So it's a privilege to have Dr. Padikwa is both a colleague and friend. And thank you for joining us. I can also see that Dr. Yvette Arthur, who is also a senior psychology intervention team in the southwest of London, is also here with us this evening. And I can see Dr. Arthur has been posting, has been making some comments. And stay tuned. Next month, Dr. Arthur is going to be taking stage, and she's going to be dealing with what is therapy. Therapy is another elephant and enigma in our rooms, in our community. And thank you, Dr. Padikwa, for joining us. And so Dr. Arthur is going to be dealing with that. So stay tuned for May 2023. I think 2024 is going to be the 30th of May. That's Thursday, 30th of May. And it's going to be everything about therapy and what it means. So thank you, Dr. Matiola, for that answer. Now, I'm just thinking in terms of just moving on. There are quite a number of questions that have been featured here. One of them is about Do you think that schizophrenia could also be due to a spiritual cause? That's one of the things that's been said. So over to you. What's your take on that?
Yeah, I think I should first clarify that I'm a Christian myself. So before I'm a
Absolutely.
Christian, but also a psychiatrist. But I can definitely assure you that I do not believe that schizophrenia has a spiritual cause. And I think that there's a lot of work that churches and, religious organizations can do working alongside mental health services. And that they do actually, in fairness to them, quite a lot of churches are now more open to working alongside mental health services. And it's interesting that, religion does come up quite a lot with psychosis, because as you can imagine, whatever your background is can be reflected in some of the symptoms that you get. So if you're somebody who comes from a very religious background, you might find that the person is talking about religious things. And we see that very commonly. People's delusions can sometimes be religious. That does not mean that it's been caused by, spirituality, but, people's beliefs system is reflected in how they present. So you wouldn't have somebody who lives or who was born in England talking about, there's somebody who is mixing medicine in my backyard, or that sort of thing. They will have different type of delusions. So our culture can reflect on the symptoms that you experience, but I certainly do not think that that is what causes schizophrenia. I definitely believe that there's a place for prayer, and I encourage people who get comfort from prayer to pray alongside taking their medication. So the best thing would be to be able to walk alongside churches for people who seek a lot of comfort from their church, but also church leaders encouraging people to take medication for when they've got psychosis, just as they do when they've got diabetes or when they've got hypertension. You take your medication and you pray. So that's what we would encourage.
Thank you so much for that. Could I ask to be unmuted, please? I think, all right.
I think there was
I'm just trying
something
to
about
unmute myself.
okay, because I saw that there was a delay. I was just going to just comment. I
Yes,
thought
good.
there was somebody who said if they don't take
Yes.
oral medication, can they be offered something different? So I was just going to quickly say we offer injections, just like with different types of medication where you've got the oral and the depot injection options. We have that, and for a lot of patients, they benefit from injections because then you can just take that once a month, as opposed to taking it, having to remember every day. I mean, when I have a course of antibiotics, I don't always remember to finish the course of 7 days. So imagine having to take medication for a year. So we definitely have options of injections for people who want to take that.
Right. Okay. Thank you for that, Dr. Matiola. So in terms of just talking about how people take their medication and encouraging people to take their medication, I think one of the things that you said that was really very key is the role of church leaders. Because I do think that church leaders, community leaders, religious leaders play a very vital role in working with mental services to really be able to support the service that we deliver. And like you say, we are not where we need to be yet, but I think we are not also where we used to be. I usually joke that the very first time I spoke to a church community was in 2001, and I could remember the trepidation with which I approached that very first meeting. I didn't know whether I was even going to be thrown out of the hall because, but things have moved on a deal now, and there is some very good practice taking place where church leaders are really working with mental services to try and promote things. And like you say, when people have diabetes or they have thyroid problems or they have high blood pressure, we don't ask them to throw away their medication. So in the same way, it's best not to ask them to throw away medication. And I also feel that it's important for instance, one of the reasons why we do the WhatsApp group for Christian leaders and ministers in the workplace is to really be able to support people who are in this position of leadership. I think that we need to recognize where our giftings are and to use other people's giftings when it's necessary. So thank you for really talking about that. I think there are a number of questions that have been asked in the chat that I'm just going to begin to bring up now. Somebody said, how can the onset of delirium and dementia be delayed? How can the onset of delirium or dementia be delayed or outcome? I think that I do wonder whether you want to have a go at that or not, because I know it's not really the theme for today, but what would you like to see on that, Dr. Matiola?
I didn't get that. How can the onset of delirium be what?
And dementia be delayed or overcome? Yeah,
So
I
delirium,
suppose I suspect that.
I was just going to quickly say that delirium is usually so if you treat the underlying infection, that should usually resolve the symptoms. With dementia, we have colleagues who work with memory clinics and psychiatrists who work with memory clinics who the GP can refer to, and then they can support people with dementia. So they're two different things. Hope that helps.
Absolutely. I think it's important. Yeah, just like you clarified that there are two different things, two different conditions. One of the questions here, what is the difference between psychosis and schizophrenia? I know you already tackled on that, but if you could please touch on it again.
So schizophrenia, one of the psychosis is, I've already explained what psychosis is, and different things, different causes of psychosis exist. Schizophrenia is just one of them. So schizophrenia causes psychosis, but schizophrenia, psychosis is not schizophrenia, if that makes sense. Dr. Ajayi frozen. You're back. Okay. Okay,
right. Yeah. So like you said, I do apologize. I'm many miles away from town, so or from civilization, maybe. So it's
hence the greenery behind you.
Yes, hence the greenery bit. Name, I don't think, but I'm sure we'll get through this. Thankfully, I've got very eminent assistants who are doing a good job. So basically, as Dr. Matiola said, that psychosis is an umbrella term. It covers several conditions, and schizophrenia just happens to be one of them, maybe the most widely known of them. Somebody said about their son being diagnosed with psychosis at the age of 14. Please explain in view of your submission, is it that it is rarely present in young people? Okay. So if you could just say something about that in terms of how quickly can psychosis be diagnosed in young people? And
so psychosis can, yeah. So I'm in general adult psychiatry. So for us, we start from the age of 18. We have consultants for children and adolescents, and that's for children up to the age of 18, who usually look after children experiencing all forms of mental disorders. It's rare to have psychosis that young, but that doesn't mean it can't happen. But it's usually late adolescence that you have psychosis. So it might be that maybe the person has a prodromal syndrome, which was I touched on in one of my slides, that, you know, towards late adolescence, so from the age of 15, 16, 17, you might start seeing some symptoms, but the usual age of presentation is from about the age of 18. That doesn't mean that it can't happen earlier, but the treatment is the same. So if the person is diagnosed with psychosis, it will be treated with antipsychotic medication.
Right. Okay. Thank you very much for that, Dr. Matiola. For those who are in the know, I've suggested that I switch off my camera. That might help a bit. So I don't mean to be rude, but maybe that will help. So that's why you are just seeing my photo, not my face. Uh, please, what are the chances and implications of misdiagnosis? That's another elephant in the room. I'm sure Dr. Matiola has a lot to say about that. I have some thoughts as well. Please go for it, Dr. Matiola. And by all means, I know that Dr. Fadipa is in the house as well, and also Dr. Arthur. If you have any thoughts, please just throw it in. Let's all benefit from this collective wisdom. Please go ahead, Dr. Matiola.
So misdiagnosis, I wouldn't say that it cannot happen. Misdiagnosis can happen, but to be honest, it's not a big deal, because if the person has psychosis because of bipolar, or they have psychosis because of schizophrenia, or they have psychosis because of drugs, the treatment is still the same. So in terms of diagnosis, it's more important for professionals. So it's more important for me and my colleagues and the GP to be able to say, this is schizophrenia, or this is depression, severe depression with psychotic symptoms, or this is bipolar disorder. But for the patient, all they want is to be symptom-free, to be treated, to feel better. So as long as they're receiving the adequate treatment, I'm not saying that it's right to misdiagnose somebody, but I'm just saying that it doesn't take away from the fact that the patient is treated and gets better. So we don't offer a different type of antipsychotic because you've got schizophrenia or because you've got psychosis from cannabis. It's still the antipsychotic medication. So misdiagnosis, and for a lot of the people that I work with, even if I suspect schizophrenia, which by the way is a combination of some of those symptoms I showed you, has to have gone on for at least a month. I don't rush to diagnose people with schizophrenia just because of the negative, effects it has from all the negativity that we've had in the media and so on. I make sure that we take time really to establish that this is truly schizophrenia. So usually we would say it's an acute psychotic episode or first episode psychosis or drug-induced, and really take time before we make a diagnosis of schizophrenia. If it's very obvious, then we do. And we explain that. And we also say to patients and families that it doesn't mean that it changes the way that you're treated. The treatment is still the same. Hope that helps.
Thank you so much for that. I think it's important to clarify that the name doesn't really matter. The medication is still the same. I suppose another thing that I hear people if people get given a diagnosis of psychosis when there's no psychosis. And I just wanted to reassure that the College of Psychiatrists is doing quite a lot on that. I've done quite a lot of work, and there's still quite a lot ongoing in terms of us offering the culturally appropriate service. Also, these days now, we are even talking about spirituality and about how we need to understand people's background, not just their social background, their spiritual background, their cultural background, in order to be able to provide a good service. So constantly, psychiatrists are constantly having support, constantly refining how we practice to make sure that we are delivering a service where people don't get lumbered with the diagnosis that is not theirs. And like Dr. Matiola said, interestingly, I think interestingly, I had this conversation just recently where I was saying that it's these days particularly a diagnosis of schizophrenia because it's early days. We we are also open to that idea that we're still seeing where how this is going to evolve. So for
I think Dr. Ajayi's reception, I'm going to try and look at the chat. I think somebody was asking about whether people can come off medication, antipsychotic medication, even if they've been on depots, and the answer is yes. So what we just do is that we don't just stop the medication. We tend to reduce the medication and monitor the person. And even after you stop it, you still want to make sure that for months after you're still reviewing the person, because when people relapse, it's usually sometimes, especially if they've been on injections, it can take up to 2 to 3 months before they relapse. So we don't just stop it, we monitor the person even after we stop the medication. But yeah, people can come off medication. Someone said the son was if you're referred to early intervention and rejected. If you feel that you've been rejected and your son still, or the person still has symptoms, then go to your GP again. People might be assessed and might not be found to have the diagnosis, but maybe if they're referred back and the symptoms have got worse, they can be reviewed again. Because that's the other thing I touched on, that there's a prodromal phase. So if you're in the prodromal phase, you might not be treated, because we don't want to be giving people medication unnecessarily unless they need it. So if you find that your family member has deteriorated and you're still concerned, don't hesitate to go back to your GP and ask for the person to be referred again. Explain to us the relationship between psychosis and stigma. Well, there's no really real relationship between psychosis and stigma. It's just what, some aspects of the media might have, reported negative effects. A lot of my patients, recover from psychosis. They go back to university, they go back to their jobs, and they live normal lives. So there should really be no stigma with psychosis. Once you start taking antipsychotic medication, is that a life sentence? No. So if you stop, do you risk relapse right after you take the medication? So I think people worry about this a lot. And that's why if you want to come off medication, you should do it with your doctor. So with your psychiatrist, and just follow their advice. So they know how to take you off the medication. And if they say the person needs to stay on the medication, then the best thing to do is to follow the advice of the doctor. What can the person suffering from schizophrenia do to help themselves? I think it's just to take the treatment. So just to take the medication prescribed, and to engage in the treatment that has been advised. People believe that once you have a diagnosis of psychosis, it's for life. How true is this? Can one have a complete recovery? Yes, you can. You can completely recover from an episode of psychosis. And we see that a lot of the time. Is antipsychotic medication given injection form? Is the medicine released slowly into the body over a period of time? Yes. There's a hand raised. I'm not sure.
Hello, good evening. Sorry, it's me, Yvette Arthur.
Yeah.
Clinical psychologist. I just wanted to contribute towards the question about stigma and psychosis.
Okay.
If I can, because I've seen in my practice there can be a link with stigma and psychosis. So whether there's stigma in the community about mental health problems, and that leads to a delay in help seeking. And so I think, Doctor, as you've highlighted, it's so important for people to get early help. But for some people, they're very worried about the community getting to know that their loved one might be quote unquote crazy or mad. That's also the connotations that we hear around psychosis, and that can lead to delayed help seeking. It can also lead to help seeking from non kind of NHS statutory means. So the person might rely more on prayer, right? Might rely more on herbal medication to resolve their issues. Whereas we know that you need to engage with the biopsychosocial approach. We need the prayer, and you might need some medication and therapy on top. So it can affect treatment adherence as well. If you feel like I don't want to keep attending my appointments because the hospital is located in my community and I don't want people to see me as well, stigma in that way. So yeah, it's important to hold those aspects in mind. And also for, say, a young person taking medication who's maybe living in halls, they might be worried that they're not like their friends, and their friends might find out that they're on medication. And that's another stigma that we have to talk through and work through the person so that they can have the best outcomes. So apologies, I just wanted to contribute to that bit.
No need to apologize. Thank you. Thank you for that contribution.
problem.
And I agree as well. Yeah, that's great. Thank you.
Dr. Matiola, I'm wondering whether as we wait for Dr. Ajayi to rejoin the call, whether it would be helpful if I moderated and read out the question, please, so it's easier for you to just do it that way.
Yeah.
And for those in the audience who might be listening, don't be deceived. This is not Dr. Ajayi. Don't be deceived by the closeness of the voice. I'm his twin brother. I'm just stepping in until he joins back the call.
Thank you.
So
I raised my hand just for that as well, but I'll leave it to it, sir. Thank you.
I'm sorry.
Yeah, I'm Dorcas. I was just about to say the same thing, that could I be reading out the questions to help, but yeah.
Thank you.
Yeah, thank you.
Thank you. So there's a question about can antipsychotic drugs used in patients be, I think it's, can antipsychotic drugs be used in patients who are alcohol induced?
Yes. So
okay, that's a short answer. Okay.
So the answer is yes. So we see people who have had harmful use of alcohol or have alcohol dependence and develop psychosis through that. Whilst you encourage them to engage with treatment programs to help with the alcohol use, you can also take antipsychotic medication as prescribed by a psychiatrist.
Thank you. Then there's another one around regarding treatment for patients suffering with psychosis due to depression. Is it more efficient to treat the depression first, and with what?
So with severe depression with psychotic symptoms, you treat hand in hand. So you need both. It's not one or the other or one before the other. You need both an antidepressant and an antipsychotic medication in that case.
Right. Thank you, Dr. Matiola. There was also another question which is a bit further up the chat, and it's something around, is there a relationship between, I think this is autism and psychosis? It's been written in shorthand, but I think I'm reading that right. And if I haven't, then if the questionnaire can please speak up for themselves and correct me. But I think it's, is there a relationship between autism and psychosis?
There can be. People on the autistic spectrum can present with what looks like psychotic symptoms. So they have a higher propensity to have such symptoms. You have to really assess properly, because you don't always need to treat with antipsychotic medication, but you can have autism and psychosis. But also you can have people who just have psychosis, haven't got autism, but they present as if they're autistic, just because of the way the brain has been affected by the psychosis. So it's a very complex relationship, but there's definitely a crossover between autism and psychosis. It can happen. Yeah.
Thank you very much, Dr. Matiola. I'm just looking through to see that we don't lose any questions. in the chat. This question here says, can you recommend a peer support program for early psychosis?
I'm not sure what that means, peer support program. We don't have peer support programs.
Right, okay. I think that answers that question.
Yeah.
Right, let's just see if there are any. Also, I think previously, just about 5 minutes ago, I think there were 2 hands raised. And I just want to be sure that if there is anyone who was raising a hand to ask a question, perhaps you can just ask your question verbally rather than put it in the chat. And that gives me a good opportunity to catch up with what's happening on the chat box.
There are 2 hands.
Yeah, I'm unmuted. Thank you, sir. Thank you, Kenny. And thank you, Dr. Makiola. The presentation has been really great. And there was a question earlier on the chat about someone that has been rejected services from the early intervention psychosis service. So, and the answer, I wasn't really sure I got it, but then I was going to ask about people that have drugs-induced psychosis that have been screened out at that initial process instead of taking them on just because the psychosis was as a result of drugs induced.
You wouldn't screen them out though, just to clarify that.
I've seen people that have been screened, and that's why I kind of picked on that question when it says someone was rejected. I'm not sure they borrow where you are, but from this part of Kent and the few ones I've seen, because we have a charity where we support people, and I've kind of had to advocate on behalf of people with that. So my question is, now you said it shouldn't be, but we've seen some that have been told. Now we want to understand that they should not be screened out just because it was a drug-induced psychosis for early intervention psychosis service. Is that correct?
It is correct that, a lot of people that present to early intervention services have had their psychosis because they use drugs, and they would not be screened out because of that. It could be that maybe the presentation has resolved by the time they got to the mental health team. So if it's for example, if you use drugs, you usually would advise that you don't treat them immediately, because sometimes within a week it would resolve. And if that resolves, then you don't need the early intervention service, which, by the way, is usually a 3-year service. So you can imagine if somebody used drugs and they've stopped using drugs and the symptoms have gone after 6 days, they would not need the early intervention service. But if they present as still psychotic, then they'll be taken on to that service, or they should be.
Good evening, ma. Please, I'm sorry. My name is Akinola. I'm a family friend of the Ajayis, and Dr. Taiwa Ajayi invited me. So I joined you from North America. I'm the one that asked the question about my son, 14 years of age, being given a psychosis diagnosis around 2020. So he has multiple diagnoses, DMDD, ADHD, ODD, ID, as well as autism. And I think you know all these earlier ones that I mentioned. So my question is, really, it's a bit difficult to actually understand what is the issue with him, because even recently a consultant psychiatrist here came up with another thing, which if I remember well, he said OCD. I think it's obsessive compulsive disorder, something like that. So he has psychiatrists that follow him up. He's on medication. as young as 10, he had to go and live in a group home because of the intensity of the problem, which affects him in the classroom. So, for example, he's 18 years old now. He's supposed to be preparing for university or college. Then nothing like that is happening because he cannot even study the normal curriculum that should prepare him for college or university. So I was just speaking with his one of his special education teacher yesterday, and they were telling me what he can do. Anyway, to save your time, so I don't know if you can throw more light on whether there are specific interplay with all these diagnoses he has been given, which sometimes is really difficult
Yeah.
on what's the issue.
I'm really sorry to hear about your experience, and I think it'll be very difficult to clarify that here, the complexity of the presentation. So for him, I think, when you've got autism in the mix, it makes it very much more complex. So, the different lines of inquiry you need to do. You have to do a full assessment. You've touched on OCD, which has a different treatment. ADHD has a different treatment. Psychosis has a different. So hopefully he has a psychiatrist who can just tease out all of those different things. And that's probably why it's complex, because it's got the autism on top of that and probably can't explain properly all the things that are going on. But if he's got psychosis, then the treatment will be antipsychotic medication. But if it's ADHD, then there's medication for ADHD. If it's OCD, it's usually antidepressants and cognitive behavioral therapy. So I would just say, discuss further with your psychiatrist. But it'll be difficult to really tease that out here tonight. But I hope all goes well with your son.
Thank you very much. I appreciate it.
Thank you, Dr. Matiola. There's another question here. As a student with schizophrenia, am I limited from studying hard, even if stress brings on psychosis?
No, you're not limited from studying hard, and it's more about making sure that you are aware of the triggers of what brings up the symptoms. So it might be for some people stress, poor sleep. So what can you do to alleviate the stress? And that's why the therapy is really important. So psychologists will help to explain that and to deal with those sort of, give you other ways to cope with that stress. We have lots of people with psychosis who return back to full-time education and do well with support. So you definitely need that support, but it doesn't stop you from, completing your studies.
Yeah, thank you very much. There's another question here. I think you've probably touched on this, but it's worth bringing it up just in case you have something to add to the previous answer. Thank you for answering my question. Does it mean the patient has to be on psychotic or antipsychotics for life, or can they be stopped after he is better?
Yes, they can be stopped after he's better. So, for a percentage of people, sometimes up to 30%, sometimes lower, they might need the medication for life. But for majority of people, they don't need medication for life. Everyone is individual, everyone is different. Some people, can get over the first episode and not need medication. For some people, they might have relapses, that's treated, and it might take 5 years of medication, and then they can come off medication. That's why it's important to work alongside the mental health team and your psychiatrist. The earlier you treat, as I said, the better the prognosis, and it's about just intervening early. So not waiting for those symptoms to develop, going straight to your GP or your psychiatrist as soon as you notice anything, and getting that treatment as quickly as possible. But you don't have to always be on medication for life.
Thank you. I wonder if there are other things that you just want to say, Dr. Matiola, perhaps any extra perspective you might want to share on some of the things you've already shared.
Yes, thank you. I wanted to thank Dr. Ajayi for inviting me, and he's such a well-respected professional, and I didn't hesitate to take this invitation because of all the good work he does for the community in the church, for medical students. I mean, it's just amazing all the good work he does. So I am an admirer of his work, and it's been a privilege to join today. So just wanted to thank him for the invite. I just hope that people take away from this a positive from it, that look, having psychosis is by no means a negative thing. It can be distressing, it can be stressful, but it is treatable, and people recover from it and they go on to live well fulfilled lives. They can go back to work, they can go back to their studies and so on with support. It's just an illness, just as you would have diabetes and hypertension. It's not pleasant to have the illness, but it is treatable and people do recover. I can see that there are a few hands that have gone up. Yes. I hope it's not something I said.
Well, I think, so let's go to Richard and Liz Michelle first, and then we can go to Joy of Many Nations, the new rules of dating. I don't know if that's a name or a title or something, but whoever that person is, we'll take your question second. So Richard and Liz Michelle first, please.
Yeah, thank you so much, Kenny. We must compliment you in coming to the rescue of your brother. That was highly appreciated, even though he's still trying desperately to get on board, excuse the pun. Nevertheless, I may want to direct my gratitude to Dr. Kemi Matiola and other fellow professionals on this platform. For the other colleagues of mine in the ministry, I'm asking this question for myself and on their behalf. And we might be partly naive or lacking knowledge in this field, but nevertheless, I'll ask the question: is there a possible or a definite link in psychotic behavior traits or disorders to demonology?
I'm going to give the diplomatic answer and say, I'm not going to say yes or no, but what I'm going to say is that I'm not against prayers, so prayers, yes, but also take the medication. So, I try not to, I don't discourage people from prayers if they find comfort in that, or if they feel that that is the cause, or, I can only explain to them that there's also a science behind psychosis and that the medications target that. So the same way, if you had diabetes or hypertension, you would correct, the physical health issues. That psychosis occurs because there's an abnormality happening in the brain, and it can be corrected with medication. So take that, but also if prayers help and give you peace with it, do that as well. I encourage it.
Hope Thank you.
Answers.
Thank you for that very diplomatic answer.
You're welcome.
God bless you. Appreciate it.
Thank you very much.
Thank you very much, Dr. Matiola. There's another question here, and I'll just read it out. Are Black people more prone to mental illness due to cultural, environmental, and religious backgrounds, or is it an unfounded myth?
I think it's a myth. I think it's just that the way we present is different. So, there are cultural differences in the way people present when they're psychotic. People from ethnic minorities are more affective. I don't want to go into, start using jargon words, but there are different ways of presentation. But I don't think that Black people are more prone to mental health. I think it might feel like that because a lot of people who experience it might have been immigrants or, and I touched on that in my presentation that, if you're traveling from away far from home where you haven't got family support and, there's adversity and you're trying to survive, or you've got, financial pressures and so on, that can make you have a higher risk of psychosis, but not because you're Black, but because, of the situation of where you are. So, yeah.
Thank you. Thank you for that helpful answer. I'll also just flag that in response to a question focused on support groups and so on and so forth, Dr. Ajayi has responded offering the tripartite YouTube channel link, and B has kindly posted that link in the chat. So please do have a look at that. And thank you for doing that, B. We appreciate that. And the questions, all right, okay. I think Dr. Ajayi subsequently reposted that link. So it's right at the top of the chat. I can't see any more. Also there's a WhatsApp group QR link, and so if you want to join the tripartite care WhatsApp group, you can do so by using the link in the chat. I can't see any more hands up, and I can't see any new posts in the chat. So I am going to speak a little slower just in case there are any last minute arrivals. We don't want to miss any opportunity to get all the ounces of insights and wisdom out of Dr. Matiola. We don't know when we will have this sort of access to her. So, right, okay. Somebody has jumped in with a hand. So Richard and Liz Michelle again.
Wonder if it's an old hand. I don't think it went down.
Oh, okay, right. It's probably an old hand. Okay, well, it looks like we are all right. Okay, a question just came in. How can we reduce the aging of the brain as we get older?
Stimulate the brain, do puzzles, engage the brain, eat well. Just live healthily and make sure that you're stimulating your brain, reading and all of that.
Right. Thank you.
And all those answers, I'll also add sleep well. Because there is some research showing, for instance, that when people continually are chronically sleep deprived, that they are more chronically at risk of dementia 10 years on, 20 years on. So sleeping well is also in addition to all the brilliant points that Dr. us.
There you go.
Thank you. Thank you. I know Dr. Ayodele is Dr. Ajayi is a staunch advocate of sleep. And so you heard it from him. There's another question about is psychosis hereditary?
So we did touch on that earlier in the presentation, that there are genetic factors that contribute to developing psychosis, but it's not it's a mix of genetic predisposition and the environment that you've got that all contribute towards psychosis. So yes, it can contribute. If you have a family member that has psychosis, and it's a question we do ask, it can predispose you to developing psychosis.
Right. Thank you. You can decide how you approach this question, obviously. Why is having a brain surgery considered as a brain injury?
I don't think I said that. But obviously, if something goes wrong while you're having a brain surgery, it can, cause problems in your brain. But I think I mentioned head injury, and I said problems at birth, brain infection, tumors in the brain, not particularly about surgery, but anything that, affects the brain can predispose you.
Right. Thank you very much. And there's another question around what's the main difference between psychosis and schizophrenia? I think you addressed this earlier, but it's possible that the inquirer might not have been on the call when you did.
Yeah, we did address it earlier. We just said schizophrenia is one of the causes of psychosis. There are many causes, and schizophrenia is one of them.
Thank you very much. I'll just check, Dr. Ajayi, do you have any final closing thoughts? And if that's the case, then go ahead. Right. Okay. Well, I guess it's down to me to say a very huge thank you to everyone who has attended tonight, and a huge thank you to Dr. Matiola for a very, very insightful session. And thank you for freely sharing your knowledge, your insight, and your clinical expertise. You would see that there are lots of thank yous and appreciations coming in. So we really want to thank you for that. It looks like we will be finishing early tonight, maybe 7 minutes early or so. For those who might not be aware of it, and I'm taking the host prerogative here, or the standing moderator prerogative here, to say that the reason why Dr. Ajayi has had very unstable connection is because he's celebrating his 25th wedding anniversary, and he's slightly away from civilization, and so that's why he's not been able to join throughout the call, or has had disrupted connection. However, that also means that because you have a standing host or a standing moderator, you'll get 8 minutes discount on the advertised time. So I'm sure nobody will nobody will complain about that. So thank you very much, everyone. And you know where to find Dr. Ajayi if you need to find him. And again, huge thank you to Dr. Matiola.
Thank you so much.
Have a really good evening, everyone.
Thank you. Bye, everyone.
Okay. Thank you. Bye-bye.